used to view the world as a place where I can at the feeling of emptiness. Then along came evidence.
I need to go to bathroom.
Okay, good.
I used to give advice, see disarray in my patient's eyes. I listened to the conversation. Now the older the still got in 1 minute I held the key. Next the wall was closed from me, and I discovered that the past on pillars of salt and pillars of sand.
Okay, ready?
Yeah, we're ready. Thanks.
Okay, well, thank you for coming. We are going to have our G&G run rounds, and I'm excited to introduce Dr. Laura Garcia, who is our advanced geriatric fellow in the program. Dr. Garcia graduated from the ROC program in internal medicine and did her geriatrics fellowship last year. She has a heart for education, and she is pursuing an advanced second year as a clinician educator. Part of what our geriatric fellows do is they are part of the CSC course with Dr. Patterson, and every year the fellows are involved with quality improvement, and they need to choose a project. Last year the BA was looking into improving our revenue in the geriatric service lines, and we decided to look into our GEM clinic and our billing processes. So Dr. Garcia and Dr. Anand, who unfortunately graduated, unfortunately is not here, they work together, and they learn a lot in that journey, and there were some results that were good about the process and some challenges that we're still working on. So thank you for coming and supporting her, and she will be taking questions. So thank you, Laura.
So I kind of added some things to this. I'm not just going to go over the project that we did, but kind of go a little bit into the importance of what quality improvement is and why everyone's talking about it and why it's important that we do it. And then, as you know, the latter half of the presentation, I'll talk about my project with Dr. Anand and what we did. And I think it'll mean more if you kind of know some of the things, why it's so important. So we have a lot of objectives. And the first thing I wanted to show is actually a YouTube video, and it's not talking about quality improvement per se, but talking about evidence-based medicine. And some people kind of cringe when they hear evidence-based medicine, but it's really important. It's becoming more of a requirement. We need to be able to interpret studies. We need to be able to support our decisions when we're making risk-benefit analyses, when we're deciding the best treatment for patients. So all of this kind of comes hand in hand, basically showing evidence, figuring out what is the best thing to do. So I'm going to go ahead and switch to the video, and it's about 4 minutes. I just thought it was really catchy. If someone could turn off the other light, everyone's okay.
I used to view the world as a place where I gave the word and had the feeling of eminence. Then along came evidence. I used to give advice, see disarray in my patient's eyes. I listened to the company sing. Now the old drug is dead, we got anything. 1 minute I held the key, the next the walls were closed on me, and I discovered that my practice stands upon pillars of salt and pillars of sand. I hear the evidence bells are ringing, systematic reviews are singing, clinical evidence is the maxim, and T's are now my past. systematic reviews are singing. Clinical evidence is the maxim. MNTs are now my passion. For some reason I can't explain. Clinical studies are in my brain. Always an honest word, and now it's how I view the
So this was by James McCormack. He has a couple of other videos, and I think they're really catchy. We can turn the lights back on.
At least one of them, please.
Yeah, this is one of them, but I think it's kind of nice. It's a good summary, I think. So going back to my presentation, we also want to look at the importance of quality improvement in healthcare, how it kind of developed in the United States, and recognize, and then go into my project and why is it important to audit charts and look at accuracy for billing and coding, and then look at the process of coding and as it the front end, so the part that we do, and the back end, which the coders and billers do, and then illustrate how to use quality improvement techniques to have high impact interventions utilizing a team approach. So basically, kind of going over the importance. If you look at the accreditation for medical education, they're in their, when they outline what's required, they're requiring training and quality improvement. So this is something that we have to do as residents, it's something that we should be doing as medical students, and then as clinicians. So it's going to be a continuing theme. And there are a lot of different training programs out there. There's a lot of different certifications you can receive. And so hospitals are into it now. There's different groups and organizations that will do these projects for you. But you can see that basically it's a requirement throughout. So kind of thinking about, where did we first start thinking about quality improvement, or where was it to have a really big impact in the United States? We can think back to December 1941, which is when the United States declared war. The war actually started in September, but the United States wanted to stay out of it. And then they attacked Oahu, and we went ahead and got involved. So what kinds of things happens when a nation declares war? What kinds of things do you think? I know, it's like, what?
Send troops there.
So, travel, organization. What kinds of things are the troops going to need? I'll lead you a little bit, just guess what I'm thinking.
Specifically during World War II, we had to build our military infrastructure. Everything had been things had changed dramatically since we had done anything like that.
So we're going to have to build things, and we're going to have to do things quickly, right? It's not something that we can take a long time to do, so we're going to have to all kinds of things. Weapons, which are, highly complex things, and, it's important that they're working correctly, and that everything's, to spec. So, the United States enacted legislation to help gear the civilian economy to military production. So we kicked into gear. We're going to start putting out whatever the soldiers need, weapons, ships, submarines, everything. Military contracts were typically awarded to the manufacturer that submitted the lowest bid. So what do you think that might do? The lowest bid.
Not necessarily the best quality.
Right, you need it quickly, and the person who said I can do it for the cheapest. So maybe it's not quality, so what kinds of things might happen, do you think, if it's not high quality?
I don't know, the clothes or whatever uniforms don't last, or they're not sturdy enough. Or...
There's no standards.
Right, so we're trying to pump production up, we're doing it for the least amount of money possible, we need to do it quickly. And when you think about it, these some of the things may not be as, life on the line, but some things are. I think I already mentioned it a little bit, like weapons, or ships, or torpedoes, these things need to behave correctly. Well, when you look at it, at the beginning, Japan had the finest submarine torpedoes, and the US had the worst, okay? The Mark 14 steam torpedo with an MK6 magnetic influence exploder designed to explode the hull of the target vessel, and an MK5 contact exploder, neither of which was reliable. So sometimes the torpedoes did not explode.
Oh my gosh.
And so, that would give away the position of the boat, and that could mean, that ship would be discovered and then eventually destroyed. So for the first 20 months of the war, the senior submarine force commanders attributed the torpedo failures to poor approach and attack techniques by submarine commanders. So it wasn't the torpedo, it wasn't the system, it was the people using the system or using the torpedo. Right? So they're not really kind of evaluating the process or looking to see why, they're just thinking, oh, it's poor technique, and so they didn't really look into it very much. So the Mark 14 came a little bit later, but they corrected the design flaw. They did some testing, and basically the process just wasn't very well organized. Let's see, in 1943, the Mark 18, that was another one that came by, and there was a weightless torpedo. The range and speed was less than that of the Mark 14, and it had a smaller warhead. But the problem with the Mark 18 is that sometimes it traveled in a circular path. Ooh, nice. So it actually, it turned around and exploded the submarine that fired it. So this one had an even, I guess you could say, more of a problem. So the USS Tang and the USS Tullaby were lost because of self-inflicted hits by the Mark 18 torpedo. So the United States, they needed to think of something. So this guy was on one of the team that they used to try and fix some of these problems. Does anyone know who this is? Does he look familiar to anybody?
What is Dr. Kellogg?
Maybe Dr. Kellogg, he likes history. So this is William Edwards Deming. He was born in October 14, 1900 and died December 20, 1993. He was American statistician, professor, author, lecturer, and consultant. So one of the things so it was actually Deming's teacher that was part of the ACT Plan study due, but Deming is sometimes given credit for it, so because he, I guess, was a little bit better at teaching it and making it more easily disseminable. So this can also be called the Deming wheel, the Deming cycle, and the concept application was first introduced by his mentor Walter Shewhart. So you can also have this called the Shewhart cycle, and that was famous in the Bell Laboratories in New York. So basically he was a member of the 5-man emergency technical team. I would definitely call that an emergency. And he worked with Dodge, Ashcroft, Simon, Warham, and Gallard in the compilation of the American War Standards and taught statistical process control techniques to workers engaged in wartime production. So they were looking at the processes, they were looking at the output, they were basically doing the PDSA cycle, the plan, study, do, act. And so they were continually improving, continually studying, and so basically they were able to improve on some of these things. You can look at the airplanes. So basically in the beginning, the Japanese airplanes were they were the best. They were able to kind of just dominate. And then by the end, the United States were continually improving on their design. So that by the end, the Japanese were still flying the same planes, and we had gone through maybe 5 different designs, and by the end, we were able to kind of compete with them. So in Japan from 1950s onward, this is Deming. He taught top management how to improve design. So this was after the war. So after the war, the whole kind of statistical analysis, we didn't want to follow it anymore. We were kind of the top, top of the industry. We could do what we wanted. We didn't need it anymore. So Deming was doing a tour, and he ended up going to Japan, and they really loved his ideas. So he was teaching over there product quality, testing, and sales, the last removable markets through various methods, including the application of statistical methods. So Japan really kind of caught on to this, and they really liked that. Companies you can think of like Toyota, and you can think about like the lean method and all of that. So kind of like Deming was one of the ones that really engendered that and, you know, sparked their minds and lit that fire. So, and kind of the United States didn't. And if you look at their production, and people were wanting Japanese products because they were just better at producing products to specifications just by using that PDSA cycle. So QI work as systems and processes. We want to make improvements. An organization needs to understand its own delivery system and key processes. So you have to know what's going on. A health service delivery system can be small and simple, such as an immunization clinic, or large and complex, like a large managed care organization. So when you're looking at a particular process, you can look at a small part of the process and kind of balloon it out. So for instance, my project, I was looking at coding and billing, so that's kind of a little piece of the VA system. Or you can look at a large system, like a large managed care organization. In the CS&E course, one of the cohort teams was analyzing the ER system at UH. So you can imagine how complex that could be. So these things can be very big or they can be small. QI can assume many forms, and it's most effective. It is individualized to meet the needs of a specific organization health service delivery system. So you want to make it specific to where you are. So any solutions that I come up with for my clinic may not necessarily work for HEMOC, or you may not work in a different system. The VA is its own system, its own unique drivers, its own unique process. So each time you kind of have to do the same cycle to see if it's going to work. So going into our project, when you first come up with a quality improvement project, you want to think about who do you want on your team. So you want to include everyone involved in the process. So in this particular one, we're looking at coding. You may want to include nursing, you may want to include the faculty, you want to include, of course, the biller and coders, because they're the ones that end up having to audit some of your notes. You want to include the learners, because one of the people that we're analyzing residents, so we want to try and include those as well. Jennifer McElroy, she's the coding supervisor. She's over at, I forget the building here on One Tech. Was extremely helpful, and they had been actually looking at ways to improve VA billing already. And they were working on the inpatient side, and what they found is that a majority of the notes were billed incorrectly. And the first 2 years of them starting to kind of correct billing and coding, they were saving the VA a lot of money just by doing those interventions. So they were kind of already doing it on the inpatient side, and then the side we were looking at was the outpatient side. So usually you come up with an, oh, go ahead.
Could you clarify, who is the VA billing?
Billing?
Who do we bill?
Okay, so we,
Private insurance.
right, so we're gonna, like, I can
She's
go,
going to explain it in a
She's gonna
second.
explain.
It's
but
very
I can go a little bit. So here's the process. So basically this is the outline of the process flow from the creation of the note. Let's see. This is not working.
Use the mouse because you're sitting there.
Oh, you have to,
I think she can use the mouse, it's okay.
Because even the lasers.
because it's, you just need to plug this in here.
I will say use the mouse. This must be use the mouse.
Okay. So this is basically the creation of the content of the note, which you could also think of as seeing a patient. So this is a patient encounter, but we're going to look at it just as the content of the note. So this is the first half. The process was kind of so long, to make it easier to see, I split it into two. So this is the beginning. So if you look here, after the report, 7 days after you submit your note, the report is filtered for third-party billable insurance. So even patients that we see here sometimes have third-party insurance. Like they may have, you know, Humana or something on top of their VA benefits. So if they do, we do bill insurance if they have a third-party billable insurance person. So the reports get filtered that way. And then the other side is service connection with insurance. So then we're talking about like the ARC. There's a process by which we submit to the federal government, and then it goes into our budget. So when we're billing the federal government, it's going to go into our budget about 2 years later. But when third-party billable is going to follow the rules just like any other hospital or primary care clinic. So coding 14 days from date of service. So basically, any of the third-party billable insurance patient notes are automatically audited by billers. So they're not letting residents code a note, decide level of service, and have that go unfiltered to the insurance, the billable insurance, because basically they want to make sure that's correct. So those they are already correcting. They're correcting those across the board. So the VA outpatient clinics, those are the ones that are already getting audited. It was kind of something that we wanted to see if we could somehow compile that information to see how correct was that information, because that would practically, you may have some limits as to whether that's, a subgroup of people with third-party insurance, maybe a different type of patient, but we thought that that would be a good chunk of information, but unfortunately we weren't able to get that information. So, so here we go. And then the service connection with insurance, basically there's like a utilization review to make sure that if they, let's say they're service connected for diabetes and it was not checked on the note, that was, there's a UR nurse that will go over that to make sure that that's correct. And then ultimately it will go to VERA, which is the Veterans Equitable Resource Allocation Process. That may sound familiar, VERA. And then patients billed as VERA patient. And then the budget is affected 2 years after. So that's the difference between service connection and then the payments received, which is the bill sent to insurance over here. So you can see where that splits up.
And it's very important, that thing that you have at the bottom, that the VERA bills are not reviewed by the coder. So, there's some opportunity where we're not getting resources if we're not coding properly.
Right. Thanks, Dr. Rosa. I may not have been clear. So basically our whole project was reviewing the level of service, and so if they're already correcting these, and that's like our project, we don't need to do it. But we had plenty of these patients that we could review, and we actually had that sorted that way. So patients that were VERA patients, those are the ones that we were reviewing to see if they were correctly coded. And yes, they do ultimately affect our budget. And when we go back, so let me go back and we'll go through that. So the aim statement basically improve accuracy of coding by providers at a VA geriatric clinic from 20% to 50% by June 10, 2013. And the 20% we got was from baseline data. So that's where we got that accuracy, right, 20%. So this is just the project milestones. So a little bit about the background. The VA system does not emphasize billing and coding among providers. And basically you do a module, even I think we talked about that the faculty will do a module maybe every year or so. Not even then.
Well, that module we did this spring was like the first time we got anything.
There is a
years.
module about how the billing is set up and the trajectory of that, but it doesn't.
I know, but that doesn't teach you how to code. That just
whatsoever.
explains how the
Right.
Exactly.
So I guess like the point to draw from there is that basically there's minimal, and when I say minimal training for faculty. And the faculty are the main ones that are going to be teaching the residents. I think the residents get even less than that, if they get anything. And the fellows, I know, don't get very much either, in the way of how to code correctly when you see a patient, when you're looking at a note. So we can already start to see some barriers for somebody to be able to successfully and correctly put a level of service on a note, right? We can already see why that may be the case. One, we don't know how to do it correctly. And two, it may be low in our levels of importance. And when we start talking about barriers, that's going to be some of the highlights that we'll be able to look at. So when they were looking at the level of service that was being generated for the patients seen in the GEM Geriatric Clinic, typically they're older, they have more comorbid conditions, complex patients. So usually it's going to be billed as a higher level of complexity, but when you looked at what was actually being billed, they were being billed as lower level of complexity, so we knew that there was a disconnect somewhere, right? Go ahead.
Yeah, so are the coding requirements inside the VA for level of service the same as the coding requirements for Medicare?
They are, but they're older. It's Medicare 95 rules.
Okay.
Yeah, so basically, generally hospitals will follow Medicare rules for level of service, and we were surprised to find out that the ones that they were following right now are the 95 Medicare rules. So knowing our process, like if you would just make assumptions, we would be thinking, oh, it must be the more recent one, but no, they're going 95. So that may change, but that's important to know when we start training.
So this is probably maybe not a question you can answer. I guess what's the most recent Medicare rule and how many iterations have there been between 95 and now?
I think maybe Dr. Oates can help me. I think there's a 2010.
There is a
Yes.
2010 version, which is the newest, and is more related with things that you need to document. I'll give you an example. Before 2010, we were told that review system, all negative systems, was incorrect. So if you wanted a higher level of billing, you needed to go to the review system and write the things that are pertinent to the history. And in 2010, they said, no, now you can go back to put all review systems, negative will be enough. So there are things that are arbitrary to what the clinical common sense is, but those changes will decrease or upgrade your billing. So, but yeah, UT follows the latest Medicare because it's Novitas or manager in the state. It used to be Trailblazer, and they will really look into that. Versus here is 1995, so
there have been 2 or 3 different versions of Medicare rules since 1995?
that I remember probably 2, because we did one review like when I became faculty, like in 2004 and then 2010.
I mean, the reason organizations are so focused on this, I mean, the VA is doing this to increase its revenue stream, okay? I mean, that's the motivation. It's not really about improving care.
Right.
And so the Health Science Center, years ago, got audited by the Department of Justice. And you can pick, what they do is they pick a sample of records and they review them, and then they find an error rate. And you can pick any 100 records and you will find an error rate. Because nothing's going to be perfect. And then that gets extrapolated across the entire business, and then a penalty is imposed. So the Health Science Center had something like $9 million Department of Justice thing. And after that came this big push to train physicians to code, and then hire coders to oversee so that no claims went out that could be potentially fraudulent. And they still have an audit process. We still get audited over on the UT medicine side. And it's also meant that the notes become, it's really interesting to me to look back at a note that I wrote 15 years ago compared to the notes that I write now. The notes that I write now have a lot more information in them. And some of that is to make sure that we're not going to get screwed on the coding,
Right.
and the billing.
Well, you're right. The notes are made according to the pressures of what you're going to get paid for.
Mhm.
Like some of the examples you can think of is like family history. Do you really need, or surgical history? You may not mention that in every single note, but now you have the EMR, which automatically populates that. And so for automatically populated portions of the note, you're not going to get credit, but you can check, I reviewed this, and then it counts. So you can actually bill for higher level of service. So where they thought the EMR would save money is actually costing them money, because now I can bill a level 3 all the time because it auto-populates the past medical history, it auto-populates the surgical history, it auto-populates family history. Sure, I can review on there, check that I reviewed it, and now I can bill for a higher level of service. So, it's, good ideas, but sometimes having unintended consequences, having billing dictate what we think is in our note.
Well, the opposite side of this is, before, people would have very little in the notes, and were
Right.
submitting bills, and people were saying, what the hell are you doing? You don't document what you're doing.
Right.
Why
It
should you
didn't
pay for
happen.
this? It was fraud.
Right.
Okay? So this is, somewhere there is a balance, and as healthcare's gotten more expensive, there are these systems that are put in place to sort of ratchet this down. Looking at your process diagram, I can see why they would have the coders look over the claims that are going to the private insurers,
Right.
because that can come back to haunt them.
That will haunt you.
Right. However, if you're miscoding something that's completely inside the VA, maybe the VA
Right.
doesn't
There's
care
no
that much.
pressure to be.
Right, and there may be other
accurate.
things, there may be other factors that go into how the bureau allocation goes to each station.
Right.
Well, I just wanted to just anecdotally say, I'm the PI of this aspirin
Yeah.
randomized controlled trial. So if someone has a possible endpoint, I need to adjudicate whether they had a coronary event or a
Mhm.
stroke or whatever it is. So we often get records from PCPs outside, and they have this automated thing. And last Friday, I reviewed possibly a year's worth of notes that looked exactly the same, because they're just clicking the boxes, and I'm like, I can't tell what happened to this patient. So that's kind of a problem too. I mean, there's a
Well,
note there, and they've clicked everything, but I don't know
Yeah,
what
so
has
it
happened.
happens, it happens in the hospital as well. I mean, university hospitals, because of the copying forward. And so there's all this chaff, and it's very hard to find the kernel of what is clinically oriented. So, we have this PCMH, right? It's actually payment-centered medical health.
So you can look at the competing pressures and, so coming up with a good quality note that has an impact on the patient's clinical care. I guess that's kind of what we kind of have to pressure ourselves to make sure to do, because it's tempting just to generate the same note over and over.
Well, to speak to that just real quick, because we have that problem too in the pain clinic. So we copy a lot of these things forward. We copy, or we do the click boxes and it auto populates. We end up highlighting in bold the things that are important, because it's annoying to us when we read our own notes. We're like, what did we do here? So we ended up bolding the stuff that
I capitalize the new findings, so you can develop styles on that.
Or set it apart somewhere, where you can actually see what really happened, because, you can't.
Right.
Can you review the vesting process so they get the VERA, and also if you can review in the VERA why it's important to look into the veteran connection, because I think people
So
don't understand.
basically, a veteran has a home, a medical home. So let's say a veteran lives here in San Antonio and they've never ever come to the clinic. They've been healthy, they've been doing fine, and they decide to come in. If you do a history and physical, then it's at least a level 3, a level of service 3, and that patient becomes vested with you, meaning you own that patient, so you get a certain number of dollars depending on how complex the patient is for that year. So that goes toward your overall budget. So this is something you see, like patients that come in for dental work, people that come in for eyeglasses only, that if they're not vested, it's important to do at least a level of service 3 so that you can get credit for that patient, because they're getting expensive eyewear, they're getting, dental services, which is not cheap. And so if you don't vest that patient, you're not going to get those dollars for your budget in 2 years. So that's why vested, that's important. That's something that they really look at. And then what was the other thing?
The service connection, which you probably will show later, but that's also very important.
So let's say a patient is service connected for diabetes, and you're not clicking that, then they're not going to get those medications paid for. So it may not necessarily have an impact for you, but it can have a big impact on the patient. So if they're service connected for a particular condition, that those medications will be paid for, that service will be paid for, unless you don't click it, and then that patient will be responsible.
I have a quick question, because a lot of times I'll click that even if I don't know if it's associated. Does that hurt anybody?
Yes.
Well,
That's basically fraud. So, but she's going to show you how to look for that. They develop a video that will teach you how to look into that connection, so you are truthful to what the connection is and you don't get into trouble.
well, and I don't know if maybe that happened in the past, but from what I understood from Jennifer McElroy is that they do have a process to make sure that when you click that that's appropriate. So let's say service connection, and you click service connection, there's a utilization review. A nurse will go through and make sure that that's the right way to click that. And the other thing that I found interesting, just as a tidbit for you guys, even if someone's 100% service connected, doesn't mean that everything is covered. It means that that condition is 100% connected. So I thought legally blind, 100% service connected, everything is paid for. This person is really, everything's going to be great. But no, only for that particular thing are they 100% service connected. If I have a doubt, I'll click it, because I know that it's going to be reviewed. And but of course, if I can, I'm sure that may change in that review process. Things change all the time. You want to update what your flow chart is. But yeah, I would click it, and then there's a nurse that's going to review it to make sure that it's appropriate. So, so accurate coding is important to justify resources for patients and for future practice of the residents and trainees, but for accurate calculation of budget requirements for the services provided. So, you don't really want to talk about money, but it is, you have to pay for the building, and you have to pay for the lights, and you have to pay for salaries, so it does affect you. If you're not going to bill correctly, then, you may lose a nurse practitioner, or you may lose a staff person because it just doesn't look like you're needing it. because you're not billing correctly. So it is important, maybe just we're not quite emphasizing it, but it does impact you in the long run. The long-term goal is to increase the accuracy of the various providers of documentation, front-end coding, and increase understanding of the importance to patient and provider. So one way that we saw that was important to the patient is that, like we mentioned, service connection, so to make sure that if their medications are supposed to be paid for, that they are. So with the tools introduced by the Clinical Safety and Effectiveness course, which some of you will be taking later in the year, our clinic was evaluated for effective documentation, and the providers evaluated included residents, nurse practitioners, fellows, and faculty. And once again, Jennifer McElroy was extremely helpful. We were able to get a sample of notes, and she had a program that would randomize the charts, so we weren't picking on anybody. So we were able to audit those. So we did a random selection, and like we had mentioned previously, we're utilizing the 95 Medicare guidelines for appropriateness of level of service. And then we'll talk about what modifier 25 is. And then we also wanted to emphasize with our training, why was it important that the primary diagnosis and the number of secondary diagnoses, like why is that important? And then we can look at our baseline data. And really 20 charts is just a drop in the bucket. So, but at least we're able to get an idea. So our audit indicated a 20% accuracy rate. So like Dr. Lichtenstein said, it may or may not be representative. The more you get, probably the more accurate it will be. But this is what we got 20% when we did that audit. So we can look at process analysis tools. Some of these may be familiar to you. Brainstorming, flowchart, fishbone, survey. Does anyone use this before? I know some of you have. So brainstorming. So basically it's when you get your team together, whomever you feel is going to be associated with the process. So residents, pharmacists, whomever you feel will have direct knowledge. And so let's say for brainstorming, we could say, okay, what are the barriers to correct coding? Like, why are we not coding correctly? And in the very beginning, we mentioned a few, like one, we're maybe not getting enough training on it, maybe we're not emphasizing the importance of it. So, that may be just two of the things we might brainstorm. The flow chart we were already looking at, so that's outlining the actual process of what's going on, because that'll show you, one, it illuminates, what's going on, because you don't always know what's happening. And then, two, it can help emphasize where you can intervene effectively. The fishbone, it's also called the Ikawawa.
No, I call it fishbone. I barely speak English, so fishbone.
I know, I can see the word.
Yeah, so there's another name for it, and I don't want to inform you incorrectly, but the fishbone is basically kind of utilizing your barriers and putting them into different categories, and then you can kind of go from there. And then a survey is the other one we used in this study. So this is not an exhaustive list. There's a lot of other tools you can use to help you decide what you're going to do. So we looked at the process flow. So basically, the content of the note, so I type my note up, and then when I'm doing my coding, so that's when you're signing your note, and then it's asking you to sign the encounter. These are the different things that you can kind of click. This is not exhaustive. So service connection is one of the boxes. Level of service per Medicare, so as we define the 95 Medicare guidelines. Primary diagnoses and secondary diagnoses. So those of you who do notes or do billing, this will sound familiar. For those of you that aren't familiar, I'm sorry, just
well, everybody's writing notes on the services they are, so.
Yeah, so so this may sound familiar. And then the modifier 25, which is something that I wasn't aware of, but as going through the process, Jennifer McElroy was telling us that maybe other people were aware, but if there's a procedure done on the same day, like a vaccination or an earwax cleaning or some sort of procedure, you can click a modifier 25 to kind of expand on the billing. So the encounter information, is it closed? This might sound familiar to some people too, is that's another big push the VA has been doing, is that if the encounter is properly closed. So some of you are nodding your head, some of you don't know what that is, and that's fine. So if the encounter is open, the information's pending, so that can be from human error. So basically an encounter report is generated daily. Darren Cortez and the GEC administrator will do this process. A lot of us are not familiar with it, but sometimes you'll get an email, close your encounter. right now, like kind of an email. So that's that. And then, so attending signs the note, the counter is closed, and then 7 days from the date of service, the Consolidated Patient Account Center runs a report called Code Me. I thought that was cute. Anyway, so so these little lightning bolts were where we felt like we could perhaps do an intervention. I know it's very broad, but basically maybe informing people, you know, it's very important, the wording. We're not influencing, we don't want you to try and get a higher level of service. We want you to be appropriate for whatever service you provide. So I'm not telling you, okay, I want you to go to level 5, this is how you get to level 5, do it this way. But, you know, sometimes the content of the note, if you fill it out correctly for whatever you're doing, you know, it may make a difference. And then basically informing people how to do this correctly. And one of the other things we wanted to do was kind of train faculty, or at least make them more aware of that, because they're able to edit anything that the resident does or the fellow does. So they have an opportunity to review anything that the resident or fellow has done. So if we can, you know, educate here and have them be more aware here, and, you know, potentially they have less turnover, and, you know, than the resident, that maybe there's a different resident every month, and, or, you know, whomever, the fellow, you know, they can kind of disseminate this information. So we felt this would also be a potentially a good area. So this is the second part. We kind of looked at it a little bit. So the reports are, this is the Code Me, and basically they're divided into the third-party billable insurance and the service connection with insurance. Coding 14 days from the level of service. So 14 days after you've closed your note, it's going to be reviewed by the billers. So that's 14 days after you're going to be reviewed by the billers. So if you have an open note hanging around for weeks, you know, this might interrupt this process. It's reviewed, and then the file is sent to Patient Care Encounter, which is part of the Patient Financial Services System. And that's sent to billing in the MSCPAC, which is in Tennessee, and then those bills are sent to the insurance, and then hopefully we get paid. So that's for the third-party billable insurance. And then on this side, we're looking at the service connection, and then ultimately we're looking at the VERA, and then the budget is going to be affected 2 years after. So I think it's appropriately hard to understand. So that's the process flow chart, and we talked about how that's one of the ways to kind of find places to intervene and to know your process before you come up with a brilliant solution. So if I'm making submarine torpedoes and my brilliant solution is to educate the commanders to fire better, you know, maybe that's not going to be effective because I'm not aware of what the problem is, I'm not aware of what the process is. So this is the other one. This is where we're talking about the fishbone. So basically you look at all the barriers and then you kind of put them in similar themes. So we can look at, so let's look at people, and here is whatever your process is. So inaccurate coding in the VHM geriatric clinic, and we want to say what are all the things contributing to this issue. So we can look at people, not a priority. Would you say that, you know, you're in a busy clinic, you have 4 people waiting, you're done with your note, you want to close it, right? You want to just kind of get it off the table. So you may just be clicking it. You do a good job, but maybe you don't spend as much time, or maybe you haven't been trained, so you're not going to really, you know, think about it too much. So maybe it's not a priority. Maybe it's not a priority for faculty. They have their inbox, you know, they're getting pages, they're covering the floor, you know, they want to make sure the interns don't, you know, stumble and have a big problem. And so they have a lot of things too. So if they don't know that it's important, it may not be a priority for them either. High volume of changeover for residents. You're in a different service every month. Everyone has their own different billing. You know, everybody has their own different notes. So it's kind of hard to always know what to do correctly. High degree of variability of knowledge between faculty. So you may have that one faculty member that is the coder, biller, expert, and then you may have someone who's not, you know, is aware of it. So that's going to be variable. So that's just people. Oops. So we can look at attitudes. Lack of knowledge that undercoding is illegal. So sometimes what happens, you're saying, okay, I don't know the correct level of service. I'd rather err under, because you feel like that's less of a mistake. Undercoding is actually illegal too. I mean, they probably won't take you in handcuffs, you know, but that's also not correct. Preconceived notion that VA does not do billing. So we're the government, right? We don't bill. We're just
or telling patients everything is for free here.
Right. It's
Those
free.
are vocabulary that we should not be using because it's not free.
So, you know, that's what our impression may be. You know, it's not a big thing for us. Coding is not my problem. It is better to undercode. It helps my patients to undercode. So some of the things you can think of maybe went through your brain, or I only have a little bit of time, so hurry up. Go ahead.
I thought this was going to be short.
Yeah, I thought so. So basically our plan was to educate the faculty. We felt that that would be a higher payoff. Improve the supervisory role, increase the importance of correct coding. We talked about maybe the resident turnover is high. We can still though give them some tools, look at the video to help them figure out what to click. We did come up with some reference cards and short teaching modules, and since we're running out of time, so there was a quick training PowerPoint that we did with the faculty, basically looking at the elements of the node and how to figure out the level of service. This is the coding reference card that we came up with, and we actually printed these. So I can hand these out to you later. Just remind me, and I will find you and give you one. So, and there is a PowerPoint that will tell you how to use this effectively, but then this is your little cheat sheet that you can keep in your pocket to figure out the correct level of service. Now remember, this is 95 Medicare, okay? So please don't use this in a different system. This goes back to the whole thing about with quality improvement is it may work in my own little niche, but it may not work for anyone else. So you always have to kind of analyze your own place. Like sometimes people poo-poo the lean models because companies who adopt lean, which is basically the Toyota method, they don't succeed, and they're saying lean is not working. Well, that's because they try and implement the same process that they learned from lean into every single company. They don't modify it for that particular plant or whatever. And in Toyota, it's very successful because they modify it for each particular plant. So you have to modify it for every little area. So you have to remember to do that. So this is the training video. We're kind of running out of time, but I can...
This is going to be placed in the Geriatrics website, so people can use it widely.
So we can... a little bit.
Once you open the node template, please make sure that you enter the review of systems, because the template says all other systems negative, but this does not count. You go to the coding screen, click the encounter button on the lower left of your screen. Make sure you click on the established versus new patient. Choose appropriate level of service. A typical geriatrics patient is in level 3 or 4. But you need to have supporting documentation in your note. If you do a procedure in the clinic on the same day, please check modifier 25. Please make sure that your primary diagnosis is the one for which you spend most of your time. Try not to have diagnosis starting with a V code as a primary diagnosis, as these are preventive diagnoses.
So that's like a health maintenance would be like a V code.
Actually, as you brought that up, well, it doesn't happen anymore because I think we've educated, but a lot of the residents were using health maintenance as the only diagnosis in their note. And they're saying, but I'm doing health maintenance. And I'm like, this person has dementia and diabetes and so forth. So anyway, but I think it's just a misconception that, well, this whole visit is health maintenance. So anyway, that is a major thing that we had to educate.
So we don't have very much else on the video, but we're going to load it so that as new people come, they can review that quickly. And it's basically just the most common mistakes that we found were made on the encounter. So that's just we also put flip cards. Maybe you guys have seen them in the room. And they're more detailed on how to do level of service. And they're the VA flip cards, so they're correct for that. We did a quick attending survey to kind of see if they were mentioning billing and coding with the residents when they were checking out, and if that's something high on their cognition or something they think about. So basically, we did training on the 19th and 26th of April. And then we're uploading the training PowerPoint and video to YouTube for retraining as needed. The flip cards are available, and the laminated cards will be available for you guys to put in your pocket for the level of service. So basically with the Plan, Do, Act cycle, you want to check your baseline data, you want to look at the data, and then follow up data samples to see if your intervention was effective. So this was our baseline correct level of service, which was 20%. And the end it was 20, not 8. I need to fix that. And this was the survey data. I'm just going to scroll through this. So basically we started at 20% accuracy, and just so you know, accuracy means accurate, right? The correct level of service. So this could be either it was undercoded or overcoded. So either mistake went toward inaccurate. So just so you guys know. And then we repeated the sample at different observation periods. I think this was like in June. I need to go back. But overall, we improved accuracy from 20% to 53%. And we need to continue to do that because, you know, really you need, the more data you have, the more confident you can be that your change was effective. So return of investment. Now this is something that quality improvement you can do is basically project like how much money you saved or how much, you know, effect you're going to have dollars, because this will help show the importance to the hospital, show the importance to people that maybe are funding your project so that they can continue to fund it. So our clinic was losing approximately $46,000 a year as there were only 20% coded correctly. You can already see limits, okay? You can already kind of poke holes in what this is, but this is just like ballpark, kind of giving you an idea. So by providing more education to providers in the future and implementing this intervention at other clinics at the VA hospital, we can potentially increase our revenue by a significant amount. Now, we could also, you know, maybe people are overcoding. We don't know what types of mistakes are being made, so, you know, we just would need more information. So, the flip cards are continuing to be there. Clinic administration will take responsibility for keeping materials current and accurate, so we need to continue to analyze the process to make sure nothing changes. We want to continue to utilize these tools with future residents, and yeah, it may be to implement these in other clinics. But McElroy was already telling us that certain clinics, they've done a pilot project of correcting everybody, not just the third-party billable, which is basically probably what's going on in other systems, is the billers audit everything to make sure it's accurate. And so they're piloting that. I think they were doing hematology, oncology, and then there was another outpatient clinic that they were just going to audit all the charts, correct all the charts. The reason they're not doing that now is because they don't have manpower to do that. You know, in other systems, they have enough billers and coders to do that job. Here at the VA, it's not as, like Dr. Lichtenstein says, it's a closed system. You know, it's not really, the pressure is not there for us to be at this time. So, but they're hoping to. Did you have a question?
Well, we can say what the people who produce electronic medical records, what they're doing is like in Epic, there's this thing called Node Writer, and so you can click on these different elements, and the system will keep track of that. So, and then it's programmed to say, well, you had so many elements here, so many elements here, so many elements here, and then that becomes the level of service for that.
Oh, so to auto-generate?
Yeah. Right. What you have though, what you have then is all this canned language. And the notes, you know, lack any
personality
or any evidence of sort of interaction, personalization of the notes. And you read those things and you wonder, did the person really do it versus just, what you did, you know, they did is they clicked on it to populate that field. And you know, I can see people just sitting there going click, 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 and tacking through it. And watching them, it's like watching a waiter in a restaurant put in an order on a touch screen. You know, you have so many items from column A, so many items from column B. Here's your
Side item. What would you like with that?
Yeah.
Mashed potato?
That's right. That's right.
Yeah, you know, it's an interesting topic because it has so many issues. You know, EMR has brought good things, like I can read it, because I can't, you know, read someone's handwriting, but now it's brought up other issues, you know, automated notes that maybe have nothing to do with the visit. You know, I'm going to screen you for depression. Are you depressed? No, okay. Another diagnosis, I'm going to auto-populate that in there. You know, it's a complex issue, and I think that it's something we're gonna continue to have to examine and figure out what's the best way to toe that line, to be good communicators and to not just auto-populate notes. So I hope this was informative. Any questions? I'll try to tell you who to talk to find the answers.
Thank you.
So for my Jerry fellow, that's how you sound after taking the quality improvement course, isn't it? That inspiring. So we're going to transition to the next topic. It's related with hospital hazards and quality improvement. So stretch your legs, stand up. We made our new geriatric dentist. Can you tell us about your name and a little bit about, and everybody goes around and introduce yourself? No, no skipping, or I will get you. Yeah.
Oh, thank you. Okay, good. And I sent you my updated slides.
Yeah, Kyla doesn't respond. It goes straight to respond. Then along came evidence. I used to give advice, see disarray in my patient's eyes. I listened to the company sing. Now the old drug is dead, we got anything